Okay, can everybody see my screen?
Yeah, I think we're okay.
Perfect. Oh, lovely. Where is? Okay, so, and if anybody is coming into the session, I can't see that part of the screen. So if anyone is happy to let others in, then that would be fantastic. And just as a reminder that I say every single week that we do these, this is a learning case. We're not here to judge the decisions that were made by anybody. We're here to learn from them. And also, if anybody wishes to discuss the case or get anything further detail from me, then please do let me know. So in terms of maternal history, this lady is a 23-year-old woman, gravida 1, para-naught, BMI of 20, booking blood pressure of 102/82, low risk pregnancy at booking, only had her nuchal and her anomaly scan, so the last one was done at 20+1, A negative blood group, with her admission bloods there, HB of 106, platelets of 285 and white cell count of 17.2. Virology, NAD, but she is a possible alpha thalassemia carrier, was identified as having low HB in her pregnancy, so was on ferrous sulfate throughout the majority of her pregnancy. Just to give you a bit of information in terms of her antenatal history, at 32 weeks, she was seen in triage for a UTI. At 5+4, she passed a blood clot the size of a pound coin. Thrush was noted and pessary was given, but her speculum examination said that they couldn't find the reason for the blood clot to have been passed. At 37 weeks exactly, she was seen in triage for abdominal pain. On examination, she was os closed, and they identified her as having another UTI. Urine dip was 3 pluses of leukocytes. It was sent off, and there was no growth identified in the MSU. But that was found out after she'd already delivered, but she was given another set of oral antibiotics. At 37+1, she came back in with the abdominal pain, and was found to be 5 centimeters dilated, and therefore was transferred over to labour ward because birth centre was unfortunately closed at the time. Does anybody have any questions on that? Nope. Okay. So this was her antenatal CTG at 35+4, where they identified a blood clot and thrush, and the Dawes-Redman criteria met at 36 minutes. So she was taken off the CTG. Is everybody happy with this trace? Is there anything concerning to yourselves at all, or are we happy to just done what the midwives here have done and sent her home after she'd been given the pessary and sent her on her way?
I'm happy.
Happy? Anyone else? Different opinions?
No, I think baseline is suitable to gestation, accelerations, good variability. There's some uterine activity happening, but she was diagnosed with the UTI, I'm assuming, at that time, isn't it?
This one wasn't the UTI. This one was actually the blood clot that she passed and the thrush.
Okay, so there is uterine irritability that I can see, but apart from that, the baby's fine. The baseline is suitable to gestation and acceleration, good variability, so happy.
Okay, so just because last time everybody wanted to see sort of an antenatal CTG to compare it to the ones in labour, I just thought I'd throw this one on there just as a reference from her antenatal period. So on the 30th of this month, not this month particularly, but the month that this was performed in, this lady came in with to triage with abdominal pain and dysuria. Maternal pulse was 92. All other observations were completely normal. And at 12:40, she had a VE and her os was closed. And she was given oral antibiotics for another UTI treatment. So this is when she came in and she had 3 pluses of leukocytes in her urine, but nitrates were negative. Are we happy with this? "37 weeks.
Anyone? Come on, Basha, I saw you. Give it a go.
Yeah, it looks fine to me. I mean, she's having some irregular uterine activity.
She's having tightening. The
Yeah.
baseline, is it kind of like comparable to the one that we've seen before?
It looks.
So we do have a baseline. Is it similar?
Yeah.
And some accelerations.
Accelerations, good variability, no decelerations, normal CTG.
So you're happy?
Yeah.
Excellent.
Perfect. And obviously, because she's 37 weeks, we're happy that if the uterine activity is there, then we're not concerned of preterm labour or anything like that. So we're not concerned with that at the bottom there. Fabulous. So as you know, she went home and then she came back on the 31st. She returned to triage, still with abdominal pain. Jaws-Redman criteria met at 24 minutes, and she was found to be 5 centimetres at 1:10 in the morning and transferred to labour ward. Yeah, happy with this one as well?
Yeah.
Lovely.
Yeah.
So she was then transferred over to labour ward, and she was put on the CTG. Anybody wouldn't have put her on a CTG?
I think that means all of us want to put her on CTG.
And what would your indication for putting her on a CTG be?
She had a small APH, didn't she? A small clot, or that's it? Or
Pound-sized blood clot with no alternative bleeding.
an abdominal pain.
Yeah, the 35 weeks, yeah. Yeah, so for that reason that you'd want her on a CTG in labour?
I can't find of any other reasons at this stage apart from that. Do you have any reasons for
No,
it?
I don't have any reasons at all. The reason I ask is obviously this lady is a primate that's incredibly low risk, other than her alpha thalassemia possibility, and the blood clot that she passed at 35 weeks. Is there really an indication to put her on this monitor, low risk labourer?
No.
No. So in some instances, if this lady, if for example the birth centre was open, she wouldn't have been put on a monitor. At this point, she was coping incredibly well on Entonox. So actually, there's not really an indication for the CTG at this point. So I know that obviously when the birth centre is closed, we do transfer our women over to labour ward. However, that doesn't mean that we can't create a birth centre environment for these low risk ladies. If we've had no concerns with her antenatal CTG so far, and there's no indication at this point to put her on, we need to be able to justify why we've got her on a monitor. And at this moment, we don't really have much justification other than that blood clot at 35 weeks. Yeah. At this point, at 3 a.m. in the morning, blood pressure, pulse, and temperature, and SATs and respirations are all normal. And she was given Entonox to help with her pain relief. And she was contracting 1 to 2 in 10 at this point. Any comments on that 1 to 2 in 10, 5 centimeters?
For a primate to reach 5 centimeters quickly on those contractions, that's impressive. So she's contracting irregularly and she managed to reach 5 centimeters on that with that. So
yeah. What would we be thinking in terms of in the not too distant future though, if she continues to contract quite irregularly, 1 to 2 in 10, what would we preempting here?
If she has made to 5 centimeters with those contractions, I won't be thinking about a hormone drip.
You'll be thinking about what, Neil? Sorry.
If she has made to 5 centimeters with those contractions, I won't be thinking about a hormone drip that early or breaking the waters.
But yeah, absolutely. Just lovely. So moving on. This is her next one. Any concerns here?
No.
I would say no concerns. Stable baseline, good variability. So no concerns. I would keep on going.
Lovely. So baseline sitting 125, 130 at the moment. And you can see on this one that the contractions are possibly looking to pick up a little bit now as well. And at 4 a.m. she was cannulated. I'm not really sure what reason for. I'm assuming just as we get into our sort of labour ward brains, we cannulate the majority of women, take off bloods and whatnot. At this point, she was requesting no additional pain relief. But yeah, she was doing really, really well. 410 to 440. Again, contracting 1 to 2 in 10. I've said this at every single review that I've done. We need to make sure that if we've got, well, obviously in this case it's different because there's not a particular indication for CTG, but making sure we're maintaining that fetal heart rate contact throughout the trace is so important. And if we're ever concerned in these sorts of situations, putting a maternal pulse oximeter on is really, really important so that we can define whether or not we are picking up maternal heart rate or fetal heart rate at this point. Yeah. Just another one of those key messages. I think I've said that every single one of our reviews at the moment. So hopefully the message will become more clear to some people. So moving on again, so 0500, she goes up to the toilet and passes a good amount of urine. Urinalysis is now NAD. And then at 0530, she was re-examined and the plan was for an ARM. Happy with the plan of care?
Yeah, sounds reasonable.
Yeah, reasonable.
Yeah. Lovely. This isn't to try and trick anyone. There's no hidden meaning. I just it gets a bit more interesting. So yeah, 5:30 in the morning, 5 centimeters, and the plan is for an ARM. So 5:40, she is ARM'd and clear LICOR. And then at 0600, it's reported that she is now contracting a solid 2 in 10 and strong on palpation. Happy with this trace? Any concerns?
Stable baseline, good variability. Yeah, so keep on going. Happy.
Lovely. Same again, all happy?
Mm-hmm.
Yep. Same again, all happy?
Mm-hmm.
So 0745 has now been 2 hours since she was ARM'd. VE was 6 centimeters and the client was requesting additional pain relief. Because of the 1 centimeter dilatation as opposed to 2, she was then offered the Synto drip. Anybody disagree with the plan for this?
When was she RM?
So she was ARM'd at 0540 and at 0745 she was found to be 6 centimeters. So she's progressed by a centimeter.
In 2 hours.
In 2 hours, yeah.
Okay.
We could have given her more time.
Yeah, that's adequate progress.
Yeah,
In
so
2 hours, yeah.
yeah, so as per our sort of our guidelines at Croydon, we sort of suggest that it's 1 centimeter per hour for a multip and 1 centimeter every 2 hours for a primip. So yep, Synto wanted to start Synto. However, we've got to think of these human factors at this moment in time. It's now 7:45 in the morning. The obstetric registrar and the maternity team, all of us are probably absolutely knackered at this time in the morning. So it may be that some clarity was lost in decision making.
The guidelines do say that if after ARM, if 2 hours after ARM, there hasn't been more than 2 centimeters progress, it is for Synto. So I get giving her a chance, but then also where you have to draw a limit somewhere.
Is that even after ARM?
Yep, after ARM.
I didn't think it changed.
It's for primate. Yeah, it is.
Mr. Naguib, any suggestions at that point?
So Mr. Naguib actually now is on a plane, so I'm not sure he will be able to comment or answer. He's listening, but he is with us in heart, but I don't think he can comment.
Okay, we'll forgive him. We'll forgive him for that. So yeah, we're all in the kind of agreement. We may have given this lady some more time to progress beforehand, though.
Yeah, I think she progressed very well so far, and we've ARM'd her. So we've done an intervention. During this 2 hours, she has done adequate progress. We also have to remember also to comment, it's not only dilatation. So even though like on the slide here, I can see that she's 6 centimeter, but we don't know what position it is. Is it more effaced? Is there descent? So we have to take it all in the consideration of what we're defining as progress. So it could have been that she was not fully effaced, and now it's effaced at the station. So that also we need to kind of include in our assessment.
Yeah, absolutely. And I think there was adequate, from what I can remember, there was adequate progress in terms of other factors of our examination as well. So, and also I think that's maybe worth going forwards in terms of our guidelines and whatnot. If somebody, for example, was to SHROM, and then we were to assess 2 hours later, would we necessarily do the same thing as we would for an ARM? Although an ARM is a form of induction to bring on our labour, why would we change our care plan necessarily if we're artificially rupturing the membranes as opposed to having them rupture spontaneously? So yeah, just something to think about.
Can I also comment, Cara, is that we have to remember that everything we do, we're actually increasing. So this lady is completely low risk. So initially we started by adding a CTG, and now we ARM'd, and now we're introducing Synto. So sometimes we can be overexcited about certain things, and we can upgrade the risk category of a patient. So we need to be aware of that as well.
Absolutely. And had she been on the birth centre in this situation, you know, we would have gone through the same care plan if it was the same examination 4 hours post the last one and we did an ARM. The likelihood is we probably wouldn't have started Synto if she was coping well on the birth centre. So just making sure that we're not trying to, like you said, Maya, make all of our women more high risk than they actually need to be. Definitely good point there. So at 07:48, pain relief was discussed, and due to the fact that she was going to be given Synto, the client decided that she would like to have an epidural prior to this starting. So this is just the follow-up trace from that. No epidural or anything at this point. Client went out to toilet at 8:35, passed a good amount of urine. All again, fluid balance was all completely normal at this point. Observations are still completely stable too. So yeah, we'll continue. So at 09:25, the client was sat up for an epidural. Maternal pulse was 87 at this moment. Does anybody think that this is maternal pulse, or would we maybe consider this being a deceleration?
Cara,
Yeah.
can I just
Maternal
ask,
pulse.
like, since this topic has come up, what's like the experience of other people regarding the recent FSCs we have in labor ward? Are they finding it helpful?
So I think since the old ones that we used a few months ago, since they've done the
Mm,
changeover, I think the confidence levels of our midwives have definitely decreased because they are slightly different to use.
mm,
As far as I know, our PDM team are quite keen to start doing some tutorials for them. I know that that's definitely in the pipeline at the moment because we are getting quite a lot of people that are saying that they don't feel confident enough to
mm,
put an FSC on. And at the moment,
mm,
it's not really part of any of our training that we do in terms of our mandatory training and whatnot and any skills
mm,
days. But as far as I know, that is hopefully going to be implemented into that. So
mm,
yeah, hopefully within the not too distant future, more people will become confident with them and be able to do them more frequently because we have this a lot, Neil. I don't know if you've seen any of the previous cases that we've reviewed, but whenever women are moving positions or sat up for an epidural or whatnot, we are majority of the time recording maternal heart rate and not prioritizing our fetal
mm.
well-being in cases where actually that's the most important thing to do.
Well, I completely agree, and I also want to add, like, even myself, I also struggle quite immensely with this new FSCs. Like, I somehow like maybe I'll say 8 out of 10 times I'll fail to attach these FSCs because the mechanism is totally different from which I have worked for the past 3 years.
Yeah.
So I think we definitely need maybe a training session or something like that, which should include the doctors as well, because
Yeah.
sometimes this becomes quite an emergency skill.
Absolutely. I'll feed that back, Neil, to our PDM team and see if we can do some skills and drills on labour ward for these. But yeah, I'll definitely feed that back to the education team for you, because I think you're not the only one. And there are certain people that are used to them from other trusts and whatnot, and they tend to be the go-to people. But actually, we all need to be practicing this, not just going and finding the person that finds it the easiest and whatnot. But yeah, that's a really good point. I'll definitely feed that back for you. The positive side of this is that this midwife was really, really good at trying to maintain fetal heart rate during the epidural. Obviously, there is some loss of contact here, and maternal pulse was palpated in these instances where we're recording maternal heart rate instead. So that was really, really good. Another key message just to go from this is, if we are struggling to find fetal heart rate, or we're picking up maternal pulse instead, or we think we might be, that actually palpating it is really, really, really important to do, to ensure that if we're not got one of our saturation monitors on there at that time, then it's a really good way to definitely identify it and document it, obviously, as well. But maternal pulse being 87, we would assume probably from this trace that was the case. Perfect. So 09:45 fluids were started, as well as testos being given, and we had good contact after that as well. So moving on. Perfect. So at 10:13, Synto was started at 3 mils an hour, and at 10:30 on this trace, the catheter was inserted. Everybody happy with this trace?
Yeah.
Yeah.
No concerns from my end.
Lovely. Moving on here, at 10:45, we've increased to 6 mils per hour. And at 11 a.m., it was reported to be a query increase in baseline, but observations were completely normal. Anybody agree or disagree?
Yeah, I can see an increase in baseline, but I can also see that at the end of the trace, it's coming back to baseline again. So maybe the next quarter of the trace will solve the issue, whether it's really an increase in baseline or not.
Yeah.
And I think the increase in the baseline is just less than 10 beat per minute. So I don't think that it's something to worry about.
So we wouldn't act on it at this point, no?
No.
No.
Because also I can see the variability is all right, and I think I can see some accelerations. So the variability decreased in the middle, but I think it could be cycling. That's why.
Yeah, so we've got really, really good reassuring signs here as well. Lovely. So we're moving on now. 11:45, contracting now 2 to 3 and 10, and the midwife also documented that was palpated as well, which is great. As I say again on every single one of our reviews, palpating the uterine contractions is the most accurate way of determining if they're happening or not. We love our technology, but at the same time, making sure we're doing everything physically as well as looking on a screen is really, really important. And at 11:45, Synto was increased to 12 mils an hour. And at 12 o'clock, normal trace reported as part of our CTG review, fresh eyes. Everybody happy?
Yep.
Yeah.
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 So moving on now, we're now at 12:20. Synto's increased again to 24 mils an hour. And at 12:35, obviously now we've got catheter in situ, urine dip was still NAD. We still happy with this trace?
Yes.
Yeah.
Yeah.
Yes.
Lovely.
There is less than 10% rise in baseline, but we still be happy. The variability is fine, but it's acceptable. It's less than 10%.
Yeah. Fantastic. And very, yes, still more than 5 as well, so we wouldn't necessarily call this reduced at the moment.
And what are Her observation, Cara. Sorry to interrupt.
Normal. Sorry, Omar. I know you like me to put more of my obs on here, but they were all normal.
Thank you, Cara.
Lovely. So moving on. Again, fresh eyes at 1 p.m. Determine this trace as normal CTG. Continuing on, are we still happy?
Yep.
Yes.
Continuing on again. At 2:20 now, so at the end of this trace, the woman had quite significant rigors, so temperature was recorded as 37.2. The new midwife that took over for break relief on the next trace noted an increase in baseline, and the client was reported to be contracting 3 to 4 in 10. Even though it's not picking up very well on the TOCO here. But in terms of this specific trace, everybody happy?
Yeah.
Yep. Okay, so we're now at 2:30 p.m. We've got a slight increase, even more so in this segment of fetal heart rate, now sort of sitting at about 160. At 3 p.m. a VE was performed and was found to be, the vulva and vagina was found to be quite hot to touch, and she was fully dilated, presenting part spines but with plus of caput. And then at 15:10 septic screen was undertaken due to fetal heart rate. Maternal obs at this point, the temperature remained the same, but just due to the increase in baseline, a septic screen was undertaken. Would everybody have done the same? Any additional comments on that at all?
Did she get any paracetamol, this lady?
Not before they did the septic screen, no, because she didn't have a temperature. Temperature was 37.2. So no IV paracetamol was given, no.
But she was having
Did they
rigors,
start
and we were thinking
antibiotics?
infection.
That comes next. I think they did their antibiotics after the septic screen was taken. I think they gave IV paracetamol then.
And Cara, I think there's a period of time that where the thermometers on labor ward were not picking lots of difference in temperature. Did we notice that? Or
Yeah,
was it just me?
No, the stick ones, they lose calibration really quickly. But we were trying to, I believe, from what I can remember, they're trying to not let us use the temper dots as frequently because apparently they're not as accurate. However, because our stick thermometers are constantly off caliber, we went back to temper dots. This one, in this case, I don't know what kind of machine or the temper dots she used to record the temperature.
Because if the vulva and vagina are hot to touch, and she has a maternal tachycardia, and there is a fetal tachycardia, I think there must be a temperature at that point. Don't you agree?
Yeah, almost certainly. I think it's difficult with the equipment, but because we do split sometimes between temper dots are a good thing, temper dots are a bad thing, and then obviously the sort of stick thermometers. I don't know what the technical term for them is, but they do kind of unsync quite a lot of the time. Perfect. So moving forward, full septic screen was undertaken, CAF and MAT was given, IV paracetamol was given. Is there anything additional that people would do in this instance if they were concerned, if for any concerns?
I might have turned down the Cinto a little bit. She seems to be contracting 5 and 10.
Yeah, so Cinto is still on, sorry, let me get back to 24 mils an hour at this point, and it hasn't been reduced. But what in terms of the reducing the Cinto, what would be your sort of reason, if you can talk about that more?
Because I'm with Natasha on that one. I'm with
There's a
Natasha
baby
on this
who's
one because the
potentially
contractions.
septic.
Oh.
Go ahead, Alma.
No, I'm agreeing with you about the contractions, because as we see here, the contractions are getting more coupled, and I think it's staying more more time. That I totally agree with you to reduce the scent.
It's also because you've got a baby that's going to be slightly compromised because it's got a fetal tachycardia. So even though the contractions aren't horrendous, we don't want to be pushing this baby into a position where we're getting a hypoxia. So therefore, to allow the baby to recover while the paracetamol and the antibiotics kick in, and she's contracting 5 and 10 and she's already fully dilated, I don't think there's a downside to reducing the symptom at this point.
Yeah, absolutely. That wasn't done in this instance, but it's definitely a good thing for everyone to remember going forwards, that actually if this baby's already under stress, maybe we can just try and reduce it a little bit. Okay, going on. So at 15:57, decelerations were noted on the trace and she remained contracting 4 to 5 in 10. At 16:10, active pushing was commenced. At 16:14, fetal heart rate was 180 beats per minute. And at 16:18, this lady was put into the lithotomy. Anybody would have done anything differently? Anybody would have gone, okay, let's get this baby out now?
No.
No?
No.
Just throwing a devil's
Sorry, did
advocate
we did we give that lady an hour of passive descent? Did I miss that? Or did we start pushing straight?
She was fully dilated at 15:06, and yeah, so it was a full hour of passive descent.
So she had full hour of passive, and the last time at the station was spines, if I'm not mistaken. It was OA, but with 2+. You didn't mention the position, but I'm assuming from her progress.
The position wasn't recorded on Cerner, I don't think. Just that there was 2+ of caput.
Okay, thank you.
But the reg hadn't come in to do an additional examination. That one was done by the midwife. I don't know whether that was just because she couldn't determine the position because of the caput or whatnot, or maybe just couldn't decipher it. But the position isn't recorded on there. Would anybody have liked to have reviewed this lady beforehand?
Yeah, I would like to have reviewed her. I think even if I'm not going to deliver her straight away, I'd want to know that she was deliverable if I needed her to, and her be on radar. So I think if a reg had seen, I would have probably done an examination at this point myself to know that if I needed to deliver her, whether I could do that in the room, in theatre, etc., etc.
Yeah, and if we already have concerns that within this hour with our raising baseline as well, we may be preempting the fact that if this baby is under distress for quite a long period of time, or becomes increasingly more stressed, then if quick delivery is going to be needed, then actually having a registrar's review and to determine the fetal position so that we can decide that would be really, really good. Again, that wasn't done in this case, but definitely a learning point going forwards as well.
But the fetal tachycardia just stayed for an hour, right? Less than an hour.
Yep. So we started to sort of increase it around. Well, the baseline was noted to be increased at sort of quarter to 3, and we're now at 4:15.
And when did we say we're going to start pushing exactly on this trace that you have right now?
So the plan from fully dilated was to give this lady an hour of passive descent, and then active pushing should be commenced.
Okay,
even with a suspicious CTG, we gave her an hour of passive descent.
Yeah.
It was okay-ish before, Omar. So like if you want to maximize the chances, I would still give her an hour for passive descent. But if you look at this strip that we have in front of us, you can see at the beginning that the contractions, there's no resting tone. Obviously, as Cara said, you do want to make sure that on palpation, not rely fully only on what you're seeing on the toco. However, if I'm going to start this baby with having no resting tone, so what I'm going to do is I'm going to push this baby to start a marathon while I've depleted the stores at the very beginning. So what I would have done different at this stage is, first of all, as Natasha said earlier, I would actually give a little bit more time for this baby to breathe and rest and replenish before I start the pushing, because ultimately she's fully So we're not worried here. We just want to rest the baby. Yes, we know that there could be choreo, there could be maternal sepsis. We don't know that yet here. Let the paracetamol IV fluid conservative measure kick in. But I would definitely now reduce that Synto, if not stop it completely, because I want to give the baby a breather to get down, settle the baby before I start pushing. Because once I start pushing, what I'm going to do is I'm going to increase hypoxic stress on top of what I have already. So I actually would have given a baby a breather before I increase the struggle on this baby at this stage, only based on what I've seen at the beginning of this trip.
I agree.
Maya, just one
Yeah.
question in that. These contractions were not adequate for this lady, and just after adding the hormone drip, this lady has progressed to full dilatation. So at
Yeah.
that point, when I'm thinking about sepsis, that this baby's brain is getting cooked.
Exactly.
So
So you need
we
to support
and
this baby.
yeah, but at that point, if you look at the case, it's only choreo. There is no evidence of hypoxia. Those
But
5
now you're going to
contractions.
add hypoxia,
Mhm. Yeah,
Neil.
I'm completely coming to that. So at that point, where the baseline rose up, there was no evidence of hypoxia as there were no decelerations. Definitely, if there are decelerations, of course, we will think about hypoxia, we'll turning the center down. But now what I want to think about is a quicker delivery of the baby, and for that, contractions are one of the prerequisites. So in
Yes,
that
but
case,
now
I
here you
won't.
don't have resting tone. So
No,
you're
no,
not giving this baby a breather at all. So
no.
you will
I'm coming.
definitely doom it for hypoxia.
No. Yeah, I agree with that. But Maya, before going into the second stage, when I'm going into the second stage, I will try to, but I will need contractions in the second stage. Without that, I'm not going to deliver this baby. So instead of turning the Synto off, should we turn the Synto down? That's
Yeah,
what I'm thinking.
definitely. You can reduce it. Exactly.
Hmm.
Yeah, you reduce it or do something to kind of give the baby
Because
the breather. The ultimate
yeah,
point
because
I want
definitely
to
the
reach
baby
is
baby
give
needs a
baby a
breather.
breather.
Yeah, I agree with that, but we also need contractions.
Yeah, I
Otherwise, I'm
agree.
not going to deliver this baby soon.
Yeah, true. I agree.
Our contractions aren't going to completely stop if you turn down the symptom or even really reduce it, which is
But
got
at
to this
this
stage.
point, yeah, we need strong contractions. Other than that, second stage, we are not going to deliver this baby. And we don't
We'll
want to
see.
leave this baby inside the womb for long. Do we agree on that one?
What I think what Natasha is trying to
I think
say
also
is
if you'd
that
have
this lady
examined
is not induction of labor. This
Hmm.
lady is augmentation. So many, sorry, there's a little bit of a background noise. So
No
many
problem.
trust as well. What they do is that literally they give with a Synto
Sorry,
a
I'm on a train.
kickstart and then let it kind of progress. So some trust actually they give that Synto as a booster, because if she started spontaneously, you're literally just trying to augment. And I think I agree with Natasha. What she said is that her contractions will not stop completely, because she remember that we just were trying to give it a boost. She reached 5 centimeter on 2 contractions per 10. But yes, I think maybe I was a little bit over enthusiastic. I wanted this baby to rest completely, but you're not assuming that her contractions will completely stop. So yes, you can argue this and you can argue that. I agree.
Perfect. Any additional advances on that? Obviously, we the idea here that maybe actually decreasing the Synto, giving the baby a bit of a break, would be beneficial. But any alternative comments on that? This is, and I enjoy doing these because it's so nice to see different opinions and what we would all do differently. But yeah, does anybody
Kana,
have any additional comments?
the only thing I was thinking while looking at the trace was, since the presenting part was at spines when she was examined, and we noticed a rise in baseline after that, uh, should we have given this lady that passive 1 hour, or should we have started from there? Because the presenting part is already at spines, and we are suspecting choreo. So giving her 1 hour is actually, we are leaving the baby in the infected environment for 1 more hour. Like, just my opinion on
She doesn't have hypoxia now. It's still only a
that.
short
Yeah,
time. If she was having
but choreo.
hypoxia, I would say we need to.
Yeah.
But
No, I
the
agree with
effect
that.
on the
If she was having hypoxia, it was a different game altogether. But she is already on choreo, and the presenting part is on spine. So what else are we waiting for? The passive stage is given for the baby's head to come down for passive descent. there won't be any more descent. The presenting part is already there in the spines.
You're maximising your chance of having a normal delivery, really. I think by giving the active
Yeah,
hour, and I
but
don't think the trace was bad enough to justify not giving
but
her now.
we usually agree, but we usually start pushing when the presenting part is at spines. So this presenting part is already in spines, and we
Do we?
now know that the baby is in
but we have
choreo.
to put into consideration that there are 2 pluses of caput, so the VE could be
Agreed. Agreed. That's the only point. Only point
the
which
head
was
would
going
that
on.
could
Is
the
it
head could be
actually
up,
the caput which has reached the spines, or it's actually the baby's head which has reached the spines? Yes, I agree
and
on
also
that.
we need to put into consideration the caput, which means that the baby is somehow obstructed in some way,
Hmm?
like the 2 pluses of caput. Would we
But
consider that as
then
obstructed?
how does yeah? But then how does giving her 1 hour of passive state
No,
solves that problem?
I'm agreeing with you. By the way, I'm agreeing with you that we should not give her an
Yeah,
hour
but
of
the only question
passive.
is what you said, Omar. Yeah, I was also thinking, is it actually the presenting part is at spines, or it's a caput which has reached the spines and the presenting part is high on? In that case, passive descent is absolutely fine.
From a midwife's perspective, I think that's quite a grey area within I think that's quite a grey area within our learning, because some people do identify presenting part as where the caput lies as opposed to where the fetal head is. So another key message to sort of come from this is obviously it's fetal head that needs to be at the certain station, not necessarily the caput. But yeah, so continue to sort of do the same thing, but also, like we said, we would want a registrar to come in and assess the examination to sort of see where delivery may occur prior to getting to this point. Yes, I think Natasha mentioned that that previously when the midwife did the examination, she would have preferred to have a reg review to assess where the baby was. So we're going to move on from this one. The registrar was requested at 4:20, but I believe was dealing with another case at that point in time. As you can see, a prolonged deceleration at 16:25. This was not maternal pulse in this case. This was baby, as maternal pulse was palpated at 86, I think, if I'm thinking from the top of my head. And then registrar came into the room at around 4:30. This woman now is contracting 4 to 5 in 10, as you can see on the trace. Consultant VE was done at 16:39. Consultant VE, sorry, I've spelt it wrong, said high head and for transfer to theatre for a trial. Going from obviously what we've discussed in the last segment of the trace, what again would we maybe consider in terms of fetal well-being here?
Synto and tocolysis.
Yeah,
Yeah.
reduce Synto at least, yeah.
Yeah, so at 16:26, Synto was reduced to 12. Would anybody have turned it off?
Yes.
Yes, could have. With these decelerations, maybe yes.
Yeah, so if we think our baseline is now sort of sat at it was 160, 180, between 160 and 180 for the last sort of 10 minutes, and this deceleration's gone down to 120. That is quite a significant drop, and it does go down for about 3 minutes. At this point, we're thinking, okay, we're gonna call for help here from our midwives if we don't have the doctors present with us at the moment. Turning Synto off may have been our best option, instead of just reducing it.
Sorry, Neil, I don't know this case. This case is prepared by Cara, but this is what I was meaning by dooming this lady to have this at a later stage, because obviously we were really pushing the baby to give us this outcome in a way in the previous slide. I've not seen this case before, but I think when you see that the uterus is doing that, what else would we have expecting? So yeah, I'm glad we discussed it, but this is what you, so the baby already metabolic rate is sky high, and we're pushing it. So this is the only thing I could be expecting to see as a result from what we've seen previously.
And this is not a sick baby. Look, the variability even in that deceleration is huge. This baby is well, it just needs a break.
break, exactly.
Absolutely. And in this sort of 20 minutes from the 420 to 440 as well, we are the varying baseline, but we do go back up to 180 again. So the majority of this trace is sort of showing us, okay, baby's saying, you know, I am stressed. I am going to reduce my heart rate to try and conserve my energy. So yeah, turning off the Synto may have been our best option here. So at 1647, the CTG was discontinued and we transferred over to theatre. Luckily, in this case, because we were going for a trial, CTG was recommenced, and this was our theatre trace. So at 1704, first pull, 1706, second pull, cup was off, so they attempted to do a Kiwi first, and then the forceps delivery via 2 pulls, head and live infant was delivered. And Synto wasn't restarted in theatre. That was something I wanted to mention. So even though we've started off here, I mean, this period of time is a minute in between, but going into theatre, Synto wasn't restarted, and as you can see, she's still contracting well. In this time frame, you can see three contractions in 10 minutes, which was good, considering she hadn't had the Synto turned off. Perfect. Anybody want to play our game of guess the gases and guess the APGARs?
I think we're all going to do that.
Between 7.20 to 7.3.
For arterial, Neil?
Yes.
Any
APGARs will be 9,
advances?
10. APGARs 9, 10, 10.
Any advances? Any
agree.
differences?
I think normal gases and normal APGARs.
Anybody disagree? Anybody else want to comment? No midwives have decided to pop up, so.
I think the basic excess might be slightly also high.
And from a physiology, Maya, why would you say that?
Because I think we have seen gradual inclination of the baseline. So the baby was coping very well, trying to buffer things for a long period of time. So this baby, I think, what has been has had a good reserve to start with, but we have put this baby under so much stress and it's been coping. So I think it has used most of the buffering system it has. But it's coped well. I'm not surprised if the baby needed kind of like 5 inflation breaths, to be fairly honest as well. So also the APGARs, I'm thinking probably could be 3, 5 and 10, but normal gases and a high base excess. I don't know. That's just my guess.
Maya, just one point to note that the rising baseline was not preceded by any decelerations. So the rise in baseline was not due to hypoxia, I believe. It was due to choreo.
Yes, it is due to choreo, but also I think this baby has coped very well because we've been stressing it since 5 centimeters as well.
Yeah, but the reason I think
but
this
the
baby was
choreo
coping
doesn't
very
develop.
well. Carry on.
Yeah, I think this baby, we didn't give it. So there was a little bit of not only gradually evolving, I think that we've actually accelerated it the last 1 hour when we have really bombarded this baby with contractions. So I think if it will have normal gases, but this baby might be also sick. And this is why I'm saying probably it would have benefited from 5 inflation breaths. But the basic says because we had more than 1 hour where this baby was trying to buffer things. Because remember, when you are sick and you are having hypoxia, the hypoxia will be much accelerated than when you don't have infection on board. So you have to think of the time frame, I think, in a speed forward kind of thing, not as a gradually evolving. Yes, Natasha.
I also think that the issue here is if we'd have given the baby a break, I don't think it's to avoid a sick baby. I think it's to avoid a 2-instrument delivery in theatre, with a potential PPH and a vertebrate tear. I mean, there is a potential that if we'd have reduced the Cinto earlier, given
Yeah,
this
we
baby
could
a
have
break,
got
we might have had
exactly.
a in the room.
Absolutely, absolutely. And this is why me personally, I would have done it in a different way. I would have given the baby a proper break and then started pushing once I've resuscitated. The infection, we started declaring it only, was it, Cara, 2 hours ago or 1 hour ago? Because the mother didn't really spike a high temperature. We just declared it from a rising baseline.
So
maternal
temperature was 37.2
exactly.
at 220, and then baseline rise was noted to be, it started increasing from about 240. So yeah, within the last 2 hours.
So we had 2 hours, and she didn't spike a high temperature. This is our expertise in kind of diagnosing now choreo on CTG. She never spiked a high temperature apart from the high pulse and the rising baseline. We didn't have anything else. What do you think, Neil?
Yeah, but if there is a choreo, the baby will feel it much earlier than the mother.
Exactly. That's why you don't add stress on the baby. You give the baby a breather, and then you aim for a normal.
But a second stage, I don't think any lady can deliver without bearing down. So if a
Without,
lady is
pardon?
bearing down, in a second stage, if I want to deliver a lady vaginally, bearing down efforts are must. So every time she bears down, there will be hypoxic stress on this baby. Now
But then you give a chance for the baby to relax into
exactly.
contractions. It's like coming up for air, and then you go again.
Coming to that. Yeah, I'm coming to that. But bearing down efforts will be inevitable. Like this baby will need to have bearing down efforts. Now, the point which I was trying to make is definitely this baby was having hypoxic stress in the second stage and on a background of choreo. I feel the management which they have done, I would have done the same thing. If I see these decelerations are persistent and the decelerations were looking like chemoreceptor decels with a lot of loss of contact, definitely I would have taken this lady to theater and I would have delivered with instrumental, which I think they have done. The registrar who was present has done correctly. But my only idea was that, like, my thing, which I was thinking is that in a background of choreo, when a baby is having hypoxic stress, definitely I want this baby to relax in between the contractions, all those stuff. But I also want this baby to deliver. And for delivering this,
and especially when the head is high, also.
They're not mutually exclusive.
sorry.
That's not mutually exclusive. You can still deliver the baby and give the baby a break in between contractions.
Yeah, I'm not disagreeing with that, but up to how much? Like, do you expect this CTG baseline to come back with the background of choreo? I don't. Every time this lady will bear down, this lady will have a stress. This baby is going to have a stress. I agree with your point that we could have spaced it out much more, but eventually we would have had to deliver this baby.
Yes, Neil, but what I think me and Natasha are trying to get to is that the superimposed stress is iatrogenic. It's caused by us.
Yeah, but
so we have pushed the baby to the edge.
Stress?
Yeah, but they will have a stress, but you can also, for example, you can push between contractions. There's so many things that we can ask the lady to push every other contraction. We can ask without having this enormous stress on the baby. I mean, we still don't know the outcome of this baby. But this is why I think it's very exciting to see the various approaches of different people, as Cara said. I personally would have kind of given the baby.
If you ask me, Maya, in order to reduce that, what I would have not done is that I would have not given this lady that passive stage. Because my background will be, I will leave that passive stage 1 hour in the active stage. I will utilize that. I will rather start her pushing and space out the contractions, space out the pushing. Maybe, as we are saying, every alternate contraction she will push. And then I will have a much longer time in my second stage. You get what I'm saying? I will use that 1 hour.
Yeah, I can see your point. So you would have, yeah.
Yeah, but because the only thing which will be going on in my background is this is a choreo trace, and this baby's brain is getting cooked. So longer I'm spending inside, the longer this chance this baby after delivering is going to receive antibiotics, which the baby, I think, must have received antibiotics. I don't know the outcome yet. So my thinking was from that point that I want to deliver the baby, and I want to deliver the baby in a point. I want to plan it in a point so that the baby spends less amount of time intrauterine and spends more amount of time getting extrauterine, getting delivered quickly.
What are you proposing, Maya?
Hello.
Would we
Maya?
like to find out what the gases were?
Ah,
Yes.
Sorry, guys, I got disconnected. So sorry.
no, no.
So APGARs of 9, 10, and 10, arterial pH 7.23, base excess of -8, and a lactate of 5.8, venous pH of 7.3, base excess of -5.4 with a lactate of 3.8.
And the EBR?
Normal, less than 500.
Did the baby receive antibiotics?
No.
I'm just curious also, what was the position of the head when they
OA.
away?
Mm.
Yeah, they have done forceps.
You could do a forceps on OP.
No, I know, I agree. But they said OA like before, like taking her to theater. They examined, register, examined.
Perfect. Does anybody have any further questions at all?
No, I'm going to run. Thank you, everyone. I'm going to work. Put this into practice.
Thanks,
Thank you.
Natasha.
No, it is exciting, Cara. Thank you, because obviously it's kind of like very interesting to see different management and what we would do, what we would not do. So I'm grateful for this case.
But
And thank you,
I
Neil.
want to ask you, Maya, what
Thanks,
were you
Maya.
proposing?
Say again, Ahmad.
What were you proposing to be done differently?
As I said, I would have given the baby a breather, because we can see that. So it wasn't the fact that they decided not to give the baby a antibiotic. I hope it wasn't missed.